Welcome to AETCM, the emergency medicine channel. A 19-year-old male came to ER with alleged history of deliberate self-harm by consumption of paraquat dichloride. On initial 10-second assessment, patient was talking in full sentences, airway was patent, there was no secretion. Breathing-wise, air entry bilaterally equal with respiratory rate of 20 breaths per minute. Saturation 100% or room air. Mild crepitations posteriorly, infrascapularly. Circulation wise, BP was 140/60 with a pulse rate of 100 per minute. Disability wise, GCS was E4 V5 M6, pupil 2.5 mm equally and bilaterally reacting. Exposure wise, temperature was 98.2 degrees Celsius with GRBS of 102 mg per deciliter. On adjuncts of primary survey, we took an ABG. ABG showed no acid-base imbalance with a PO2 of 103 with saturation of 100% in room air. We also took a CBC-CRP point of care, which showed a total count of 7,000 with hemoglobin of 14.6, platelet of 2,20,000 with a CRP of 2. Then coming to a sample history, a 19-year-old male patient came to ER with complaints of alleged history of deliberate self-harm by consumption of paraquat dichloride, 24%, approximately 15 to 25 ml, by mixing in a glass of fruit juice and alcohol around 5 p.m. that day. Within 1.5 hours, patient was transported to a nearby hospital. He had 3 episodes of vomiting while on the way, following which he was received in a nearby hospital where he was given gastric lavage followed by activated charcoal 50 grams. After which patient was shifted here for further management. We received the patient at around 4.5 hours post-consumption. On arrival, patient was vitally stable, having a saturation of 100%. Coming to allergy history, he was not allergic to any known medication, no medication history. Last meal was taken 6 hours back. So, after arrival to our hospital, we initially sent all lab investigations and monitored for the patient for any hypotension or any drop in saturation. Initial point of care ultrasound was done, which showed patient's IVC was very much collapsed. So we started the patient on IV fluids. Initial 2-liter IV bolus was given and initiated on 150 ml per hour. Following which all toxicology samples were sent, including gastric lavage, serum and urine samples for paraquat, as well as alcohol and paracetamol to look for any co-ingestions. Then we also sought a nephrology consult and asked for...
Okay, so fine. So then it's for the management of the patient. So in this case, let's discuss paraquat first. So what is paraquat? What is paraquat dichloride?
It is a herbicide.
It's a herbicide. So how, what is the route in which it is getting into the body?
Route, it can be either ingested or topical, like topical application will also this thing, but most toxic is if patient ingests it.
Yeah, so it has mucosal absorption and it has inhalational absorption. There is some amount of like topical absorption from the skin level, but the amount of absorption is significantly reduced rather than in comparison to mucosal absorption. There are cases of chronic paraquat poisoning in farmers who use paraquat as their primary fertilizer. So even though they haven't ingested it, chronic absorption can occur through skin. So when these patients come to ER, proper decontamination is required for the healthcare workers' safety aspect. So as we told, mucosal, skin and inhalation is the most common absorption part. Now what is lethal dose for paraquat?
If patient consumes 30 ml, that is 1 to 2 mouthfuls of 20 to 24% of paraquat dichloride, then it is lethal.
Yeah,
more than equal to 30
more
ml.
than at least 20% concentrated solution, around 30 ml if you are consumed, that is lethal dose. So that is around 30 mg per kg, right? Very low dose. Very low dose itself, it is very lethal. What is the mortality rate we are talking when we are talking about paraquat?
99.
Yeah, more than 80% mortality is there. What is the problem with paraquat poisoning? No? No antidote.
There is no.
There's no antidote to improve paraquat symptoms. Now, as you told, once paraquat gets into our body, how does it work? What happens?
Basically, paraquat undergoes redox cycling. So what it does is it will it's an enzyme mediated cycling between paraquat and paraquat radicals. So
That is after absorption, right? Let's talk about
it
the
will
patient
initially go
ingesting.
patient ingests it.
Yes.
Cause burning.
Yes,
it will cause
correctly
burning.
tell.
When the patient ingests it, patient will have severe burning sensation. It will cause mucosal burns. Ulcers and burns, the patient will have odynophagia, pain on ingestion, following which patient might have vomiting, abdominal pain will be there. Then symptoms.
As you told, once ingested, it can cause mucosal ulcers, burning sensation and ulcers. This is one of the classical features is there. But did our patient have that?
No, vomiting only he had.
No, he didn't have ulcers, right? No. Why? Because ulceration in paraquat is not typically like caustic ingestion. You ingest acid or alkali, you get ulcers because there is that acidic activity is going on or basic activity is going on. This is not like that. This is due to cellular destruction, due to direct action of paraquat. As she was telling, paraquat causes NADPH reduction and causes oxidative stress on the cell with mitochondrial destruction. So basically it's killing your cell directly. And because of cellular wall destruction or instability, cell death is why you develop ulcers. It's not caustic ulceration. That's important here because this is why some paraquat patients doesn't have significant ulcerations when you see them initially, especially in a very acute phase, but they develop ulcers over time, like 12 hours, 24 hours into their ingestion, they develop burning of mouth, having odynophagia, dysphagia, and by 48 hours you will have a coated tongue and whitish coated hard palate. All these things will be there. But we see this immediately after caustic ingestion, right? This is immediate reaction because that action is immediate. So based on this, usually patient, especially people who have taken concentrated solution or higher dosages, will have the symptoms onset much more earlier. Lesser concentrated solution, lesser amount they have consumed, less will be the ulcerative effects of the patient. But if patient has ulceration, they will have oral ulcers, pain, erythema, erythematous patches over the hard palate, soft palate, tongue, airway narrowing can be there, edema can be there, isn't it? Patient can develop odynophagia, dysphagia, esophageal ulcers causing vomiting, perforation, hemoptysis. But these are like severe case scenarios, not like for all patients. Not very commonly seen unless it's a high dose injection. This is the reason why in textbooks it is written rise tube insertion is contraindicated.
Patient delayed presentation is there.
So in paraquat poisoning, like caustic injection, in textbooks it is written rise tube insertion is contraindicated because in caustic injection, rise tube insertion is contraindication because cellular disintegration. So you insert rise tube without not under direct vision, can perforate the esophagus, go into mediastinum, develop mediastinitis, isn't it? So to prevent that is why we don't put rise tube. This is the same concept that is put in paraquat, but in paraquat, as we just now told, the ulcers are not due to caustic injection. So if you want to put rise tube, as soon as possible is the best time to put. Obviously, after delayed presentation, you should not. Means if you can see visible ulcerations or patient has odynophagia, then putting rise tube is going to be much more tricky rather than a patient who is coming to you with acute presentation without any GA symptoms. Got it? So that's one part. Now, once it comes to abdomen, what happens to paraquat? How is it absorbed?
It is actually rapidly absorbed, but impartially absorbed. Like it is not completely absorbed, but rapidly absorbed.
Around more than 50% of paraquat is absorbed within 20 to 30 minutes. This is another one of the reasons why they tell there is no point in giving lavage to delayed presentation patients because maximum, the Paraquat already has very low lethal dose. So most, if they are consumed adequate quantity, patient would have developed systemic symptoms by that absorption itself. So giving lavage and increasing chances of vomiting and aspiration doesn't make any clinical improvement. This is one of the reasons why they tell that. But in acute presentation, especially in lower dosages, acute presentation, no GA symptoms, you can put a ratio and do a lavage, but only if within 1 hour. Only if within 1 hour. After that, there is no point. Okay. Now, as you told, most of it, more than 50%, is absorbed rapidly onto body, and then
it gets redistributed. It will get concentrated mostly in the liver, kidney, lungs, and muscles.
Basically, to places where the maximum
oxygen
blood flow is there. Blood flow is there.
Following which it can again redistribute back to serum, back to blood.
Yes. So initially it is get absorbed to all the tissues which has the highest blood flow activity, and once serum concentration increases, once serum concentration decreases, it will get redistributed from the affected tissues. So it has a very high volume of distribution. So this is another complication of Paraquat treatment. So volume of distribution, any toxin that is significantly absorbed into the body, into multiple tissues, will have prolonged activity in the body cavity. So a single treatment or a single dose of treatment may not help to eliminate it completely, isn't it? Okay. So this is what happens in the absorption part, right? Now what happens at cellular level? That's what you were talking earlier.
Basically, Paraquat goes and concentrates inside many cells in the body, especially in alveolar type 1 and type 2 cells, and in kidneys accumulates in the proximal tubular epithelial cells, following which it undergoes redox cycling, which is it's an enzyme mediated cycling between the Paraquat and the Paraquat radicals, of which a byproduct is formed, which is known as the superoxide radical, which is actually a very reactive species. So that is what causes damage, cellular damage throughout the body. And also redox cycling consumes NADPH, which is a key antioxidant in the body. So as glutathione starts reducing in the body, so antioxidant reduction is there. So this leads to either in the kidneys it can lead to renal tubular necrosis, in liver it can lead to secondary mitochondrial damage, endothelial reticulum degranulation causing hepatocellular damage, and in kidneys as well as alveolar cells damage causing alveolitis and eventually fibrosis.
Because of this, it affects most of the organs. The most commonly affected organs are kidneys, lungs, then to an extent liver and heart, isn't it? But most commonly affected are kidneys and lungs. Now, kidneys, as you told, there is direct injury to the kidney cells, and that it is excreted at the level of proximal convoluted tubule, which causes renal tubular acidosis. So what will you see in patient, like because of this mechanism, what will you clinically see?
Renal parameters derangement, acidotic breathing.
Acute kidney injury will be there, and severe acidosis
will be there.
Renal tubular acidosis, so severe acidosis. Severe normal metabolic acidosis can be there, renal failure can be there, but more than this renal tubular acidosis induced AKI, there will be direct kidney cellular injury to the kidneys. So the kidney injury parameters will be significantly raised in comparison to the time of ingestion. Within hours, patient can go into significant renal failure and a renal compromise, which we usually won't see in other conditions. So obviously, following that, patient can go into oliguria and anuria and other acute kidney injury damages can be there. That is in kidney. Now, second thing, as in told, liver, once it is metabolizing, liver injury, hepatitis, hepatic degeneration can happen. But unlikely, patient will go into coagulopathy and other complications. See, another thing is in heart, arrhythmias. Most commonly, arrhythmias are the most common cardiac complication that you get, and ischemia-like features will be there. Now, coming to lungs, which is the most commonly affected organ, and even if with proper treatment, even if kidney failure can to an extent controlled, almost all Paraquat poisoning patients develop some amount of lung fibrosis. So lung fibrosis is the end result of pulmonary injury due to Paraquat, and most of the patients develop that. Now, what are the things that predispose this patient for this much lung injury?
Because it gets
One
concentrated
is
in the
increased
lungs.
blood flow to the lungs. Second is already lungs oxygen. The oxygen rich environment is there. So this super reactive agent will cause more damage in presence of oxygen. So lungs is the ideal organ in which it will cause massive amount of destruction. That is why patients develop pulmonary fibrosis. So because of this is one of the reason in which in Paraquat we don't give oxygen for mild hypoxias. Isn't it? How much oxygen, at what level do we introduce oxygen?
Less than 90% saturation.
Less than 90-88% saturation only we will introduce oxygen to the patient. And even when we introduce oxygen, our goal is just to reach 90-92% saturation, not more, or to alleviate severe tachypnea, isn't it? Positive airway pressure ventilation and mechanical ventilation and all is not at all going to help the patient. Patient may require positive airway pressure ventilation or mechanical ventilation and all, but increase in FiO2 will directly cause increased damage to the lungs, right?
Then we had sent for the routine investigation for the patient, wherein we had done the RFT. Renal function test was within normal limits. Creat was around 0.7. We had also done an LFT. There was no signs of any hepatitis. OTPTs were in the range of 30. We had also sent for serum and blood and gastric lavage samples for toxicology, wherein we got the result as lavage and urine sample showed presence of Paraquat, but serum samples for Paraquat were negative. It was a qualitative test, so we don't have the quantification.
But it doesn't matter, no? Like you just want to detect Paraquat in the bloodstream. Because whatever be your bloodstream concentration, is it going to change your management? No. So you just want Paraquat confirmation to initiate treatment. That's what you want. Quantitative is not at all useful. Now, from this report, what inference can you make? Your gastric lavage was positive, your urine Paraquat was positive, but your blood Paraquat levels are negative, right? This is what your qualitative toxicological analysis gave. What does that mean?
It means it was the dose was not lethal enough.
Yes.
The urine function was not deranged, so it went out in urine, because usually once urine RFT gets deranged, that the prolongation of excretion happens.
Correct.
So since creat was normal.
Yes. So Paraquat, as it is readily absorbed, it is readily starting to excrete also. So urine Paraquat will be positive within 2-3 hours of Paraquat ingestion. So this patient has urine positive, Paraquat positive. That means body is excreting. But the important thing is his blood concentration is negative. That means whatever excretion is happening is decreasing the blood concentration to the level that it is not detected. So for some good thing, this patient was not significantly affected by the Paraquat toxin. So this patient might have a better outcome in comparison to other Paraquat. So this is one way you can think about prognostication of this patient, isn't it? Okay.
ECG was also taken, which showed no signs of any arrhythmia, normal sinus rhythm. Following this, we informed nephrology and we had asked for a hemoperfusion for the patient. Hemoperfusion was initiated within 2 hours of arrival of the patient, and it was a session for of 6 hours. Following which, we monitored the patient's RFT, LFT, as well as ABGs on a continuous basis. There was no desaturation during hospital stay. There was no signs of any hypotension also. Lactate was normal. Oxygen saturation was all throughout 99 to 100%.
On room air.
On room air with the normal creatinine. So we initiated 2 sessions of hemoperfusion. Once on the day of arrival. Following 1 day, another session was done.
Okay, so you called nephrology initially itself for hemoperfusion, right? Why? Creatinine is normal, right? So why did you want a nephro consult?
It's not hemodialysis. If creat would be deranged, we would go with the hemodialysis with the hemoperfusion.
Okay.
Since it was only, it's a absorbable toxin. So we wanted charcoal hemoperfusion so as to remove the toxin from the blood.
Okay.
So that's why we went ahead with hemoperfusion.
Yeah. So this is what type of toxin is Paraquat? Finally, it is coming to that. What type of toxin? It's a large volume distributable toxin, which is mildly bound to the proteins of the body. So, when any toxin, if you want a toxin to be dialysable, it is better to be water soluble. Any water soluble toxins are better dialysable. Protein solubles are not so dialysable because the most common protein it gets bound to is albumin. So we can remove albumin as much. So protein soluble toxins is usually removed by plasmapheresis. You have like filters and plasmapheresis. That's what you do to take out. Basically, you remove the plasma which has albumin and put in new plasma. So the concentration of the toxin will be coming down. Or you use absorbent methods like charcoal filter or other filters, resin filters to absorb the toxin from the albumin. That's what you do. Now, the complications of this method is bigger the size of the toxin, bigger the protein binding, and hydrophobic types of toxins are the least effective in hemoperfusing out of the patient. So, ideally, there is a list in TINALI about the types of toxins that can be dialysable that needs to be gone through. So, when we think about calling nephro, we should identify these toxins to see what type it is and what can we do about that. Now, as you told in this patient, if it is a water soluble toxin, we could have just done a hemodialysis. There is no requirement of hemoperfusion. This is not hemodialysable because it's not water soluble. That's why we went with hemoperfusion. This patient might also require hemodialysis if there was renal failure, and that hemodialysis will be to support renal function rather than toxin removal. Yes. So that's what we did. Hemoperfusion we did. So we did 6 hours.
6 hours initial, then 8 hours.
6 hours window. So 4 to 6 hours is the time usually that hemoperfusions are being done. Doing dialysis with the hemoperfusion obviously increases the life of the cartridge. More time we can use, especially in renal failure patients. Otherwise, since he doesn't have renal failure, we didn't go for that. In these patients, what are the complications that you will see when you start hemoperfusion? Hemoperfusion is being done. Now, what is the drug that has to be given for hemoperfusion? Heparin. It has to be heparinized. You have to anticoagulate the patient for the hemoperfusion, not like systemically, but for hemoperfusion. So, this patient might have hepatic injury. So, giving heparin can cause significant bleeding risk. So, even if there is no hepatic injury and bleeding risk, these patients, if they have ulcers in the mouth and GI tract, can develop upper GI bleed or oral cavity bleed, which can cause airway compromises. So, before hemoperfusion, if there is active ulcers in oral cavity and all, we may have to think about securing the airway, if at all there is a bleeding risk. So, that is one complication that we can think about. Another thing is about hypotension in these patients. Already arrhythmia risk and low BP will be on the lower side. Hemoperfusion can worsen that. This is the complication that we do. Now, you initiated hemoperfusion in this patient. Now, what are the factors that, support better prognosis after hemoperfusion? Like initially we told the selection of toxin. Those factors we cleared. What else in Paraquat part? What specific parameters improves the chance for good prognosis for a Paraquat person who has to undergo hemoperfusion? In simple words, when will you start hemoperfusion?
We will start
as soon as possible. As soon as possible, before 4 hours. Before 4 hours is the best time to start hemoperfusion. But this patient is 4.5 hours, no? So why did you start?
Because we can't take a chance.
This is a very young patient. Luckily, he still has a good urinary excretion amount and he haven't taken a higher dose. But Paraquat's major problem is delayed presentation too. Since earlier we told of large volume and distribution, these patients can initially look very stable. They may not have any symptoms. They may look at you, talk with you, and be very happy in room air. Over 48 hours, 24 hours later, slowly from other tissues, paraquat will start leaching out into systemic circulation, developing paraquat features. So, irrespective of patient's initial status, if we are getting a patient as soon as possible, like within 4 hours and all, we should always give the option for hemoperfusion, because right now, other than hemoperfusion, we do not have a standard treatment which can improve patients' mortality and morbidity, isn't it? Or is there any other newer things that is being currently studied?
Yeah, we have adjunctive therapies.
What are the adjuncts?
So basically, we can give antioxidants. So antioxidants, as in like we can start the patient on N-acetylcysteine, the dose being around 150 mg per kg for initial 3 hours, followed by 300 mg per kg. We can continue up to 3 to 4 weeks.
What is the idea behind that?
This is basically antioxidant.
Basically, NADPH depletion is what the cells are facing. So we are just giving N-acetylcysteine, hoping that NADPH regeneration will occur. That is the idea behind N-acetylcysteine. Okay.
And we can also go ahead with vitamin C. Vitamin C 300 mg BD we can give.
Still antioxidant effects.
It basically will donate electrons. Vitamin C will donate electrons to the free radicals and try to neutralize them. Another one is desferrioxamine. That is around dose of 100 mg per kg over 24 hours.
So basically, what is that?
It is actually chelates iron.
So iron chelating agent, but in this case, its action is
catalyst. Basically, it's iron acts as a catalyst in production of hydroxyl radicals. So it will go and chelate the iron. So it will stop producing the radicals.
But none of these things are being clinically proven to improve patients' clinical condition. So when will you use these parameters? These experimental parameters, when can you take it on a patient? Obviously, N-acetylcysteine and vitamin C is not going to harm the patient, so giving it to patients are fine, but desferrioxamine is not like that, right? So otherwise also, when will you start these treatments? On much more poor prognostic patients. Like early patients, we have clear criteria to start hemoperfusion, but patient presents to you very late or refer from outside because of worsening of paraquat features or already on mechanical ventilation, hypoxia, severe renal failure. We already know there is poor prognosis. We are going to tell the bystanders is poor prognosis. In those patients, we can start these experimental things and see whether any improvement might happen, isn't it?
Steroids. Steroids.
So what is the other treatment that we can give?
We can give pulse steroids, like we can give methylprednisolone 1 gram for 3 days, followed by dexamethasone 8 mg TID.
Yes, high dose steroids. Why do you give this?
Because
to prevent lung fibrosis. The whole idea to give steroid in paraquat is to provide support to prevent lung fibrosis. That is the whole idea. Or what is the negative effect that we may face?
Infections.
Increase in infections. Patient's immunity is already compromised due to oxidative stress. We giving steroids may literally invite infection, but otherwise pulmonary prognosis is pretty bad. Okay. Now, what are the complications after a successful treatment of paraquat?
Most common presentation, patient will come back with pulmonary fibrosis.
After 4 to 8 weeks, most of the patients who survives will develop pulmonary fibrosis to a level. So, restrict of quality of life, activities, frequent infections, all these risks has to be informed to the patient while discharging. What else? Persistent renal failure, recurring hemodialysis is another complication that you will face. But in consideration of mortality more than 80%, any patient who can be saved is great. Okay. Anything else?
Nothing. I think that we have recently we have a drug called edaravone. Edaravone is basically a free radical scavenging antioxidant. Plus, it is an anti-apoptotic drug, anti-necrotic and anti-inflammatory with anti-inflammatory effects. So it actually delays the development of pulmonary fibrosis. It won't prevent it, but it will delay the time at which it will start. And we can use ECMO, but it is not proven as of now. In case any patient is being planned for lung transplantation, which has been done previously, to bridging time, we have to use ECMO for the patient till lung transplantation is done.
The only way to improve patient's quality of life is plan the patient for lung transplant. And in this case, it will be very good because due to the toxin that caused, you transplant the lung patient will be completely normal. That's it, right?